Hello everyone. Welcome to the third episode of MedUpdate. I hope your day is going smoothly. My name is Zehran Punika, a student with aspirations to become a doctor. In this podcast, we discover the new developments of medical treatment in detail. I will be joined once again by two of my great friends, Taha Kazi and Fahad Sultan, who intend to become doctors as well. This episode, we will be joined by our renowned guest, Dr Mohammed Munavvar. Dr Munavvar is an interventional pulmonologist who has brought the first LungVision navigational platform to the UK. This episode, we will focus on what LungVision is, how it helps us, and what we can look forward to in the future with similar technology. I'd just like to ask if you could elaborate more about who you are and your successes, please.
So I'm Mohammed Munavvar. I'm a respiratory consultant at Lancashire Teaching Hospitals in Preston, and I've been here for 25 years as a consultant now. I qualified from Chennai in India and did a couple of postgraduate degrees there in medicine before moving to the UK and training in Manchester, and finally settled in Preston. I'm also honorary clinical professor at University of Central Lancashire and have a special interest in interventional pulmonology, which involves minimal access techniques in the chest. So I work with innovative techniques. I'm involved in a number of projects looking at advanced diagnostic procedures, all with minimal access, either through the mouth or the nose or through the side of the chest with a little keyhole. Those are my main interests, although I'm also lead for tuberculosis in this region.
Thank you very much. And that would be usually very non-invasive procedures. Would that be classified as non-invasive because those holes are already usually open?
Yeah, a combination, because some of them I have to make a keyhole on the side of the chest with ultrasound guidance. And others most of the advanced procedures are through the mouth, either with a guard in the mouth, or if they're under general anesthesia, there will be a tube in the mouth already for general anesthesia. If they are basic procedures, we can also use a small camera where you go through the nostril and then go into the airways and into the lungs. So, yeah, in a way, semi-invasive. They're not truly invasive, most of those. And even the keyhole procedures I do under local anesthesia and sedation. So that's why they are called minimal access procedures, not like surgical procedures, minimal access.
Yes. Okay, thank you very much. We would like to start off with Taha. He'll be asking the questions initially, and then we'll move on to me and ending with Fahad. We're talking about LungVision, so please go ahead, Taha.
All right, to begin, Dr. Munavvar, can you explain what LungVision is and how does it work?
Right. Essentially, it's an advanced diagnostic technology to help us navigate into the lung, to the depths of the lung, so that we can access lesions in the lung or abnormalities in the periphery or deep inside the lung, which we could never access before. Why is this important? Because lung cancer, particularly, it's also used for other conditions in the lungs, but principally for lung cancer. And lung cancer has become more and more aggressive over the last few decades, with nearly probably more than 35,000 people dying in the UK alone every year from lung cancer. That's the first thing to say. It's one of the worst conditions that you can ever be diagnosed with very high mortality. So every 15 minutes, somebody in the UK dies due to lung cancer. And once a diagnosis is made, as it stands, it's made at an advanced stage, and therefore people die, 1 in 10 people with the diagnosis die within a month. We talk so much about other cancers, but if you club breast cancer, bladder cancer, prostate cancer, leukemia, all of them together, still the number of people dying of lung cancer is higher than all of them put together. So we needed to make a difference. And the only ways in which we can make a difference is, first of all, for everybody to quit smoking or don't start smoking at all. Smoking cessation, it will make a massive difference. The other way is to diagnose the condition early, as early as possible. If you diagnose in a very early stage, you increase the chances of survival more than tenfold. So this is where LungVision comes in. Because with late diagnosis, there's only a 5% chance of survival. If you make a diagnosis early, small lesions in the depth of the lung, then you increase the survival chance to almost 55%. And how do we make the diagnosis? That is the biggest challenge. You have a number of reasons why we are picking up these smaller and smaller lesions. For instance, now in the UK, you have a bowel cancer screening program. You have something called CT, coronary angiography, to pick up lesions in the blood vessels in the heart and stenosis, etc. You have now something called targeted lung health check, where CT scans are done almost like screening. And all of these show very often incidental or diagnostic lesions inside the lung. They're diagnostic by scans, but they're not confirmation. You don't get confirmation that they are actually malignant lesions. They can be non-cancerous lesions. So when you say lesion, it's a little shadow or a spot inside the lung.
Yeah.
So how do you make a diagnosis? This is where LungVision comes in.
Okay, thank you. That's an amazing answer. So the next question I was going to ask you is, what is the purpose of the creation of LungVision?
Yeah, very good question, because over the last few years, there are a number of attempts with technology to try to guide us inside the lung. The challenge is that lung, if you go into the trachea, the windpipe that is trachea, and then the bronchial tree, it divides and subdivides like the branches of a tree. So you have something like 16 plus divisions. So if you imagine putting in a camera into those divisions, the chances of getting lost inside the lung is very high. And the chances of getting to that spot, which you see on the CT scan, is very low. Now, we needed to find something which will help us navigate inside the lungs, just like GPS. You want to know, you want to get to your friend's place somewhere where you've never been. You need to know the street, first of all. You need to go accurately to the street. Then you need to get to the house, because just because you've got to the street, it doesn't mean you'll find your friend's house. So similarly, you can easily get lost, and this is where you needed a navigation kit. So now you have a whole field called navigation bronchoscopy. And there are a number of new technologies approaching this, and one such technology is LungVision.
Oh, okay, thank you. So the next question I was going to ask you is, what's the typical procedure of a bronchoscopy with LungVision?
Okay. So normally when we do a bronchoscopy, we introduce a camera, usually under sedation, through the mouth or through the nostril, go into the throat, have a look at the voice box, that's the vocal cords, insert the camera further, look at the trachea, then go into the bronchi and the subdivisions. There are 10 major subdivisions, branches, shall we say, of the tree on the right side, the bronchial tree, and 9 major subdivisions. Each of those divides into further divisions. Now, when you do a bronchoscopy, normally you'll go to some of these divisions and that's it, it stops there. You can't go beyond, you can't go into the lung. With LungVision, the normal procedure is a CT scan where you've detected a spot deep in the lung. You take the CT scan either on CD or by PACS link. It's called a PACS link, where you digitally link into a tablet which contains the LungVision software. Then you load it into that software. It does an analysis and shows up that spot. Then you have to plan a pathway which that software does in conjunction with yourself. And I say with yourself, meaning you have to choose the spot, you have to mark the borders on that tablet, and then it creates a pathway up to that opacity or lesion or spot. That's the first step in the tablet. The second is there's a whole computer unit, the LungVision unit, which talks to this tablet, and through it, It connects straight through to your C-arm. The C-arm is an X-ray machine. It provides 2D images during the procedure. Now, what this LungVision does, it converts those 3D images, transmits it to the C-arm, so that using a 2D machine, you get 3D images during the procedure. Does that make sense?
Yeah.
So using artificial intelligence to convert that, and then LungVision, what it does, it helps you navigate to the lesion, to the spot, and then it tells you where you are by looking on that X-ray machine. The X-rays are taken during the procedure, and real time, you can see where you are. The reason I say that is without LungVision, the lung is a big structure. It's a really big structure. And if the spot is right in the middle of the lung, if you're in front of it or behind it, it will show on the 2D machine as though you are in that spot. If you introduce a forceps, for instance, to take a biopsy. This 3D reconstruction, what is called as technologically as C-arm-based tomosynthesis, shows us the 3D image, so you can be sure that you get to that spot.
Oh, okay. So to simplify, would you say LungVision is a very important and beneficial software during bronchoscopies and other similar procedures?
That's correct. So without it, just to give you an idea, in the past, going back, say, 20 years, getting to that sort of a lesion, a spot inside the lung, in the depth of the lung, even if you use real-time X-rays during the procedure, was less than 25% the chance of getting. And then you may not even get adequate tissue to make an accurate diagnosis. About 15 years ago, we used a miniature ultrasound probe, which increased the chances to about 50 to 60% from less than 25%. Now with LungVision navigation, that opportunity, that sensitivity has gone up to more than 80%, close to 85%. It's a huge leap. Plus, with its use, because you can see exactly where your tool, your biopsy forceps is, or your needle is to collect the cells, because you can see real time, you can safely take samples without causing any damage to adjacent structures or go through the lung, because effectively you could go through the lung and damage and cause a leak, air leak, but that you can prevent here as well.
Yeah.
So it's efficacy and safety.
And it's relatively new as well. Okay.
It's very new. In fact, in Europe, you have only 3 centers now with LungVision, 2 in Italy and 1 in Preston. So only 1 in the UK.
That's amazing and very aspirational to hear, Dr. Munavvar. So I want to ask you, what motivated you into bringing LungVision into the UK?
Okay, so the last 6 years, I mean, my passion has been in technology, innovation for lung cancer or lung lesions. And I've been working in this field for more than 20, 25 years, collaborating with various companies who make new products to try and bring these to Lancashire and South Cumbria to our patients, and of course throughout UK, and then disseminate internationally. So about 6 years ago, I started on the path to do some research to find the best possible kit. And in 2019, early 2019, remember it's January 2019, what happened was I came across a different kit, which quite expensive. It cost £200,000. So I did a business case, and went and presented to the Rosemere Cancer Foundation board. And they were very supportive, and they approved the money for that particular piece of kit. It was not LungVision. It was a different kit at that time. And we went down the route of acquiring that software program and the kit to do something similar. But whilst we were doing this, we were hit by the pandemic. So for 2 years, 2.5 years, we couldn't do much along this field, couldn't advance it further, our desire to get this new technology. And by the time, whatever additional research could be done, showed that this new kit, which is LungVision, was around the corner. So I waited for it and decided then in 2022 or thereabouts to go down the route of looking at LungVision. There were some advantages over the other technology. One being, very importantly, the lack of the need for additional consumables, because in the NHS, like anywhere else in healthcare, you want something to be effective, but you also want it to be cost effective, right?
Yeah.
Otherwise, you will end up spending a lot, and that will deprive other specialties, other patients, other technologies of that bit of money that you have, because you have one common pot, right? So the desire is to continuously enhance the service, but also make it cost effective. So the other technology that looking at seem to have a need to buy additional tools, little accessories, which was pushing up the cost. Whereas with LungVision, there was no additional tools. You use existing accessories. So this looked very attractive to me. So I did some more work, looked at the evaluation in US, a couple of studies which were being pursued. So then I thought we'll move to LungVision, and went back to Rosemere Cancer Foundation, had to get the approval. Then the challenge was, because it's a new company and they had not brought kit into the UK, there were a whole lot of other governance measures for safety, because you have cybersecurity, you have clinical governance, you have information governance, a whole lot of hurdles, appropriate ones, because you need to make it safe as well, to jump. And so I had to set up a huge team, about 15 of us, working in close collaboration. That included people from this country, from Lancashire and South Cumbria mainly. Then you have procurement clusters. Then you have the charity itself, and also expertise from Italy, people who are working on LungVision there already, technical experts, that is. And so I had to bring them we had to meet like this every week for several weeks. I think it took about 12 weeks to get it all done. And then the final step after that was to bring the kit and make sure that it fits in our theater and our unit. So with the help of IT and the medical engineers, we had to put everything together on one trolley so that it was completely portable. So all these steps before we started.
So you described that there were many challenges, such as portability and stuff. What would you say was the biggest challenge when bringing it here?
Well, the biggest challenge initially was to ensure that we had the funds, because these things, the NHS plan, naturally, there's a lot of pressure in NHS for lots of services. So within the NHS plan, it's not possible to include expensive pieces of kit like this. And this is where organizations like the Rosemere Cancer Foundation play a major part. So I've had the pleasure and the privilege of collaborating with them over the last 2 decades for both fundraising as well as applying for funds to improve care and the use of new technology for patients. So that was the biggest challenge initially. The second challenge was all these governance issues, because supposing it's an existing company, for instance, there are a number of companies who provide, like Philips or Olympus or Siemens. They're all known companies who already are within the framework. There's something called NHS framework, and they are approved companies by the NHS framework. Now, if you go to a completely new company, and this company is called BodyVision. Now this from California, this company, then to get all the approvals, a number of them, there are a number of forms to be filled, and all, I would say, are all very important. They're appropriate, because you don't want to expose your patients to something which is not completely approved. So those were additional challenges. And then finally, to introduce a new system into a hospital, comes with some challenges as well. There are some safety measures to be taken. There is what we call as an SOP. There's a standard operating procedure to be used, etc. So a number of other challenges.
That's an incredible journey, Dr. Munawar. Well, that's the end of my session, and I'm going to hand it over to Zahra now.
Thank you very much. Those are very detailed, very thorough answers. So thank you for that. And thank you, Taha, for asking those questions. My first question for you is actually touching more on what you did say before, more about what sets LungVision apart from the current technologies that do similar things with the scanning, with diagnosing and treating lung cancer. Because you did mention how how LungVision had a lack of need of additional consumables, and that in turn saved money over time. So in terms of more to do with the safety, the accuracy, the reliability, and the ease of use, are there any differences between LungVision and other platforms, navigation platforms?
Very good question. There are a number of navigation platforms. I explored the possibility of acquiring at least I looked at 2-3 other platforms. There are pros and cons with anything. One of the other platforms that I looked at and required a specific piece of kit in addition. So every patient we have to use. In fact, 2 of the platforms actually mandated the use of a specific accessory, which one, it was quite expensive, and 2, it was a little bit more, I would say, tricky to use. 3, another important difference, with LungVision, you get something called augmented fluoroscopy. This is a term which is used because fluoroscopy is chest X-ray screening. So you do a chest X-ray, it's a still image, like a photograph, right?
Yes.
Fluoroscopy is like a series of moving images. So real-time moving images. So if you look at the lungs, and rather than just having one single image, you have a series of images. So when you introduce your camera, you can actually see where your camera is, where your bronchoscope is. And then when you introduce your biopsy forceps through the bronchoscope, it comes out, and it's actually, you can see it moving, and you can see it in relation to the spot. Now that spot is so tiny often, it's just a question of 10 to 15 millimeter, 20 millimeter. So on the chest X-ray image, it will not be seen. So what this does, this LungVision, is by calculating, using artificial intelligence, calculating where that spot is in the lung using the CT images. Now, CT scans take 200 to 300 images. By calculating all of that, rather than a spot, like a little spot or shadow, it shows as a ball, a yellow ball. It's more spherical, not a circle, but more spherical. So that sphere, which is present, a ball, is called augmented fluoroscopy. It is augmenting what you see as moving images, so that you can see in relation to your bronchoscope and in relation to the biopsy forceps or any other accessory. So that was a big difference between other technologies and this. Of course, the other thing is some of the technologies, the operating systems were a little bit older. And this was the latest operating system. So it was more about compatibility. It was compatible with what we had with most of the existing X-ray machines. X-ray is like a C-arm. You see, I don't know if you've seen X-rays, like a C-arm. So the C-arm can be like a cone or a flat panel C-arm. So this was compatible with most existing C-arm. What we did not want to do is to buy an expensive piece of kit costing nearly £250,000 and then find that it's not compatible with some C-arms, some X-ray machines, and compatible with others. So this also gave us the freedom to use any of the C-arms or the fluoro X-ray machines which are available in the hospital.
Yes, that's a good point, actually. I do remember reading that LungVision is very compatible with, I believe, all bronchoscopy tools. Correct me if I'm wrong.
Yeah, it's compatible with it because you have a connection to. It's got to synchronize, and have a connection with the machine which takes the X-rays, and it is compatible with that. And and the bronchoscopy accessories. You don't have to use a specific kit. You can use whatever you want.
Yeah, which is very great. Its accessibility is a massive advantage for new technology, especially when
Absolutely.
integrating it with older technologies.
Yeah.
But yes, just following up with that, um, are there any more shortfalls that LungVision has that you may not have covered?
Yeah. No technology is perfect. We need to improve even further. Now I'm working with the company and I've sent my feedback to try and improve the accuracy, for instance, of the navigation, the pathway that is created, the GPS that is created, like your Google
Yes.
Map or any GPS, same thing. So sometimes in certain areas, for instance, with the GPS, you could get to a place and when you go in a car, sat nav, you can get to a place and you think, oh, this is not where the house is not here. In fact, there is no house here, you know? And
Yeah.
similarly, there are some errors that can happen with this, and we need to make it even more accurate. That's one thing. The second is with the lesions, which are or spots which are more than 20 millimeter to a 2 centimeter, and if they are away from the main blood vessels, aorta, etc., not right in the center, then it works really well. But some spots which are smaller or closer behind some of the major blood vessels, there are some occasions where you can't get it accurately to that spot. So there are some limitations, and therefore the diagnostic yield, we call it a diagnostic yield. That is, what is the success rate essentially? In medical terms, it's called diagnostic accuracy or diagnostic yield. It's
Yes.
about 85% now with these, and we want to be at well over 95%. Ideally, we'd like 100%, but that is difficult to achieve because of so many variations and spots in the lung. There's a spectrum, it's not one type. So we want to push up the diagnostic yield further. Any other limitations? Well, you do use X-rays. We want to limit the exposure to X-rays as much as possible. So LungVision is good in the sense that exposure to X-rays is low, but maybe we need to look at being even better. We've got to continuously improve. So there are a few little limitations like that. But overall, it's really good technology.
Yes, definitely. And I guess more to do with those negatives. Are there any associated risks? I know it's a navigational platform, but in terms of the entire procedure, you're locating deeper nodules. Would that come with more risk to the patient?
Fortunately, with this technology, the benefits hugely outweigh the risks. When it comes to navigating navigational bronchoscopy using LungVision, the risk of causing complications is relatively low. So that's a huge advantage. Of course,
Yes.
we couple and it integrates with smaller bronchoscopes that we use now, which also makes it more accurate as well as safe. So, and I don't see any other significant problems with the technology.
That's great to hear. Coming on to the next question. How is artificial intelligence used in LungVision, and is it reliable?
Yeah, great question because the whole platform, the whole software is dependent on artificial intelligence to convert those 3D images and those multiple CT sections and create a pathway, also show where the blood vessels are in relation to the pathway, and finally, to convert that static 3D, the 3D images and create 3D images intraoperatively using simply a 2D platform. That is
Yes.
where it's hugely important and artificial intelligence plays a role. It does not obviously do everything. You have to make sure that you guide and select the right point, and there are lots of measurements. So LungVision navigation has a steep learning curve. There are numerous steps to it. So in fact, there's a study in the US where they looked at operators who are using LungVision navigation. And very interestingly, they showed that you need to do at least 10, ideally 20 procedures before you get to a stage where you're more comfortable with a number of sophisticated steps that you have to take to register the spot, register the pathway, and utilize the navigation facility.
Right. So in light of that, would you say that training would be required for people who use LungVision?
Absolutely.
Yes.
This is a completely different piece of kit. It's not as though everybody who does bronchoscopy, everybody who does even advanced bronchoscopy will be able to pick it up straight away. It requires structured training, and it requires a great deal of repeated training. It's not you have to refresh your training, you have to keep doing your procedures, you have to do a significant volume of procedures to maintain the skill as you go along with this technology.
Okay, thank you. And in terms of the trials run, research gathered, could you please describe the general results, the consensus from that research on the effectiveness on LungVision overall?
Yeah. So what it shows is that with the use of LungVision navigation, along with, as I described as augmented fluoroscopy, which is part of that, and along with that, the use of what is called radial EBUS mini probe. That is radial endobronchial ultrasound using a miniature probe, something that we already been using for nearly 10 years, more than 10 years now. When you combine all of that, there is a progressive, each one of those leads to a progressive increase in the diagnostic accuracy. On top of that, we use, and this has been shown in quite a few studies already. Admittedly, there were observational studies, initial observational studies, but there are publications. There's one from Cleveland Clinic, then a few others from principally from the US, where it's been used extensively, LungVision. So all of them show that the diagnostic accuracy goes up progressively as you add on, use it in combination with all this technology, achieving 85% at least, if not more.
Right. And just to get a clearer image of this, when doing bronchoscopy, do you just have two screens, one from the LungVision camera feed, the live scan, and then the other from the RP, EBUS, the radial probe, endobronchial and ultrasound? Is that what the case is, or do you have more information around you?
Yeah, there are numerous multiple screens around you. The first screen is your bronchoscopic image, that is the endoscopic image.
Yes.
The second, specifically to LungVision, there is a monitor. That monitor synchronizes with your X-ray machine monitor. So there's another monitor for the X-ray machine. So the two can be synchronized, and you can see the still image as well as moving image of the X-ray and the LungVision. The third screen is your tablet, where you are controlling all of this. So the tablet is here next to you. The bronchoscopic screen is in front of you, and then these other screens for LungVision, and then the X-ray machine. In addition, when you're using your radial EBUS, your endobronchial ultrasound, using miniature probe, on the same bronchoscopy screen, you can press PIP, picture in picture, and you can get the two screens within that same monitor. So there are a few different monitors for you to look at. So
it's just like using a tablet now, using all that very accessible software, integrating it into healthcare needs, and honestly, that is a very smart move, I believe, in my opinion.
Yeah.
But yes, I would like to focus more on those medical scenarios where you are doing this procedure. Are there any specific types of medical scenarios where this is more effective than other medical scenarios?
Yeah, quite specifically, because with the expansion and the number of an increase in the number of CT scans that we carry out for various reasons, either specifically targeted toward lung cancer or indeed for any other reason, if you do a CT scan, you have to analyze the CT scans and you end up very frequently picking up spots which you did not expect. So they are called incidental nodules, incidental SPN, solitary pulmonary nodules. Now, you don't know whether those nodules are new, have been there for some time. You don't know whether they are benign or malignant. If they are non-cancerous nodules, are they because of an infection or some other condition? The only way forward then is to take a biopsy from the nodule. The alternative would be to wait and do what is called an interval CT scan after a few months. If you do it too quickly, there won't be much of a change. Ideally, if it's possible, after doing a risk stratification, risk assessment, you will plan to do a biopsy. And this is where the whole issue arises of how to get to that area so deep in the lung. It's a massive challenge. It's a huge struggle world over. It's not just here, because do you do the extreme measure of opening up the chest or using keyhole procedure surgically to get to that lesion? You may not even be able to feel it. You won't be able to locate it because it's so big, the lung. Do you then instead introduce a needle from outside whilst doing a CT scan? Possible. What is called CT guided lung biopsy. But there's a risk of leakage of air, risk of bleeding, and so on. Or do you do a less invasive procedure, which is through the bronchoscope? And for that, you need some additional tools like LungVision, ultrasound, radial ultrasound, etc.
Right, so it's a much more complicated process, actually. There's a lot of factors to consider at once.
Absolutely, yeah.
Right, and could you just tell us more about your anecdotal experiences of using LungVision?
Yeah, I mean, we've chosen patients carefully to get the maximum benefit in the first few months that we've been using it. And we've had, I would say, pretty good results where it has made a meaningful difference to the management and outcome with patients. It's really quite a leap forward with regard to making an accurate diagnosis and planning treatment, what is called targeted therapy or personalized therapy. When we started, there was a great deal of excitement because it's the first of the country. So there was a BBC team who came and shadowed us, and it was telecast on BBC. But what happened, I'm only mentioning that because what happened is a patient from another part of the country, near Manchester, outside our patch, because we are Lancaster in South Cumbria, had a problem where he had gone to his doctor in his local hospital as well as regional hospital, and they could not find a way to access the lesion that they had been detected on the CT scan without causing complications. So he had come effectively against a brick wall. But when he saw this program, he went to his consultant in their local hospital. I requested them to contact me, and we brought him over, and we did the LungVision navigation and ultrasound, and he got an accurate diagnosis, went back, relatively young person, and he got the desired treatment. So it started like that, and then now we are rolling out in a part of our course. We run a national course for these sort of procedures here in Preston. It's only one of two major courses in the UK. The other one is in London and Brompton. And we've been able to teach other consultants around the country. We want to disseminate this besides other technologies.
Yes, so there's a lot to look forward to. Thank you very much. That's the end of my section. And now we'll move on to Fahad, who will end our podcast with his questions as well.
Thank you, Zehran, and thank you, Taha, as well, for those questions. Very insightful. So, Dr. Munavvar, I would like to just be enlightened about certain procedures, such as cryobiopsy, and how especially LungVision can benefit the procedure of cryobiopsy.
Very good question, indeed. Now, cryobiopsy is where you use a probe through the bronchoscope to freeze the tissue and then take out the freezing is done using liquid nitrogen or carbon dioxide. So the tissue actually sticks to the probe and then you pull it out very successfully. Initially, we were using the cryoprobe to what we call debulk lesions. That means if there are cancerous lesions in the main airways blocking the airway and therefore causing breathlessness, we would use this cryoprobe, a little device through the bronchoscope to freeze the tissue and then take it out. Now, cryobiopsy, we've got a smaller probe. Originally, we had 2.4 millimeter probe, 1.9 millimeter probe, 1.7 millimeter probe, smaller and smaller, and now we've got a miniature 1.1 millimeter probe. Now, this probe can go deeper into the lung and then help us to freeze during LungVision bronchoscopy, help us to freeze the tissue and therefore give us larger samples. Why do we need larger samples? In this day and age, it is not sufficient to just say whether it's cancer or not, whether it's lung cancer or not, or whether it's a type of lung cancer. There are 2 or 3 major types, but what you need is subtype. And then you also need molecular diagnosis. There are a number of different markers, biomarkers, molecular markers, for which you need adequate amount of tissue. So if you take a tissue just with a biopsy sample or with a needle, you may not get enough tissue to go and do all of this molecular analysis. There is something called next generation sequencing, molecular sequencing. Why is it important? Because if you have a particular molecular marker positive, you can then use targeted therapy specifically for that, rather than using generalized chemotherapy. Improves the efficacy, reduces the side effects.
Yeah, thank you. That's very interesting about cryobiopsy as well as how LungVision can help with it. My next question would be most about the software itself. So what would be the cost of installing and also maintaining a LungVision machine compared to other similar machines? And as well as that, do you believe that it is worth investing in LungVision if it will provide overall benefit to the patients and the NHS?
Yeah, so the LungVision software and the whole system costs somewhere around 200 to 250,000 pounds. In addition, there's a very specific carbon fiber table that you have to use. Otherwise, there'll be interference when you're taking the real-time X-rays and doing the screening. So there are other machines of a similar cost, but as I mentioned, the other machines require very dedicated accessories which cost more. As far as maintenance of the machine is concerned, once installed, there is a maintenance contract in case there's a service contract in case something goes wrong, and also upgrades as they continue to conduct research on this machine. Then you need to have upgrades to make sure that you're using the latest, just like anything else, your laptops, your phones, anything, you'll have software upgrades. So that also has to be factored in. They're the main things that you need to look into when you're managing with LungVision.
Thank you about that. Now, have you received any feedback by patients or technicians or even doctors about this technology, such as yourself? Have you received anything similar?
Yeah, fortunately, we are in a position to help patients across Lancashire and South Cumbria. Anybody, in fact, the patient that I referred to earlier was from Manchester. So people get referred from all over the place. It's within the national press. So we've had contact from people elsewhere. We're trying to help set up in this and other regions. But the feedback from the consultant specialists referred from elsewhere has been so far quite very positive, because they have had challenging scenarios, clinical scenarios, where they are not able to make an accurate diagnosis. And thanks to the use of technology such as LungVision with miniature ultrasound, etc., it has been possible to get an accurate diagnosis. So feedback from both the referrers, the referring specialists from elsewhere, as well as the patients has been very good. We do these procedures in general anesthesia, so the patients are very comfortable. Fortunately, we've We have not had any significant complications. So we are trying to minimize complications as much as possible. There are some lesions which are very close to blood vessels, so they can bleed a bit. So we have to factor that into consideration. But overall, the feedback has been very good.
That sounds very positive, and it should be, because this does seem like promising technology that could be very useful for the future as well. Speaking of the future, we have a few questions about how the technology could advance. So how would you see LungVision or even similar scanning technologies improving in the foreseeable future in interventional pulmonology? So you did mention also about the accuracy improving in the future, and you did briefly talk about how that potentially could lead to better percentage of just gathering data and how it could be improved. So could you elaborate on that, please?
Absolutely. Specifically for LungVision, as I mentioned earlier, there are some limitations. Like any technology, no technology is perfect. So we have to work on those limitations to try to make it even better with LungVision. I mentioned about the navigation software, accuracy. I also mentioned about the amount of radiation that we use, which is actually low, but we need to make it even lower. So that's for LungVision. Now, the biggest issue is the diagnostic accuracy. Now we're getting to well over 80% from 60% plus. We've gone into a jump of at least 20%, close to 85%, but we want to go even further. There are some technologies which are being evaluated and some which are available, which when combined with LungVision will make it even better. For instance, there is a robot-assisted bronchoscopy, which is expensive at the moment, which when used in conjunction with LungVision, pushes up the diagnostic yield to well over 90 or even 95%. What is that? It's a robot-assisted bronchoscope, which calculates the software to go into the lung, and small robots, because existing bronchoscopes, we have to hold them into position when it goes deep into the lung. The robot-assisted bronchoscope has stability. Once you get to a certain area, it will stay there. You can fix it there. Also, it gives you even smaller camera pictures, so you can even smaller accessories, so you can get into the lung. So that's one technology. The other technology, which is used as a competitor, which is a lot more expensive, more than £1 million at the moment, is something called cone beam CT, which is the use of a CT scanner in a cone beam fashion, already used in some other specialties, but that cone beam CT then would also help in this respect. So other technologies are being evaluated, but each of them has some advantages and disadvantages.
Yeah, that does seem at least hopeful for the future with other technologies. Speaking of other technologies, what about future developments from all around in general within the field of treating lung cancer? And how would you say these areas work alongside LungVision within the treatment of pleural diseases?
Yeah, so the next step, the whole idea of getting to diagnose smaller and smaller abnormalities inside the lungs, smaller and smaller lesions inside the lungs, is to now be able to treat these lesions in a minimally invasive fashion. How can you do that? Potentially in the future, with the use of a robot-assisted bronchoscope, a software like LungVision, you can diagnose, get into the lung, take a piece of tissue, do what is called a frozen section, where you make an accurate diagnosis then and there, and then using the same catheter, you can introduce various measures, such as, for instance, radiofrequency ablation, microwave ablation, you talked about cryoablation, use of steam, to even treat that lesion. So it's a one-stop shop. A patient is diagnosed with a spot in the lung, comes to us, we give general anesthesia, try and find that spot, make a diagnosis, and give the treatment at the same time. This is blue sky thinking. This might happen, but it's already some evaluation that's going on in some centers at the moment in this regard.
Yeah, that sounds very promising, at least easing the job of all professionals and the process itself. I think easing is very important within the upcoming future. So yeah, that does sound very promising. Well, that concludes all of my questions alongside Taha and Zehran's. So I'd like to thank you for answering and pass it back to Zehran as well.
Thank you very much, Fahad, and thank you very much, Dr. Munawwar, for sharing your knowledge and time with us and our audience. So it was an honor having you, and I hope that LungVision and future iterations of this similar technology will help save many more lives to come. And I thank our audience as well for tuning in. And hopefully we'll be able to have many more meaningful discussions with you and other doctors about these new developments in medicine, which benefit patients and staff greatly. So thank you very much. And we'll be ending our podcast here. So hopefully you'll all tune in for the next episode. And I'll say goodbye from my end.
Thank you very much. It's a pleasure and privilege to be here. Thank you.